So I think the biggest disclaimer I have is that I'm going after Dr. Isman Firdaus, who, if you do not know, is the president-elect of the Asia Pacific Society of Cardiology. And the APSC is the collaboration of 25 member countries and represent about 2 billion of the world's population. I myself am the president-elect of the ASEAN Federation of Cardiology, and I will take over the same time as Dr. Isman in 2027. And we represent Zone 2, which is actually 10 countries in Southeast Asia. So I operate in the Stroke Heart Center, which is the main public hospital, covering 125,000 kilometers on the island of Borneo. We share this island with Indonesia and Brunei, and we treat approximately 1,800 patients PCI, approximately 70% with DCB. So in terms of where we are, I am actually there in the bottom part on the island of Borneo. It takes me about 2 hours to fly to Kuala Lumpur and 6 hours to fly to Beijing at the top. And as you can see, for most of us in Southeast Asia, we are all an archipelago. We are islands everywhere. Unlike America or China or India, we have to get around with a bit of difficulty. And more than 50% of the population in Southeast Asia is actually in the rural areas. So access to treatment is actually very challenging. So this is where I am. I work in the hospital with Dr. Leong in front, doing a fellowship in Fuwai. And for us, we are the only public center looking after this whole large land area mess. To put it into context, the area of Sarawak, which we cover, is larger than the size of South Korea. It is approximately 3 times the size of New York State, and approximately a bit bigger, 3 times the size of Hainan Island. So we have a very, very big area, dispersed area. And to treat patients, they have to medevac, they have to go by boat to get to us for when the patients are very sick. So for us, we've embarked on a DCB strategy for more than 20 years. And the reason for this is because many years ago, we do not have 24-hour electricity in all the rural areas. So if you give patients things like clopidogrel to prevent stent thrombosis, the temperature, the external ambient temperature is about 30 degrees. And not all your clopidogrel is stable at 30 degrees unless you have a refrigerator. So if you're sending patients from very, very far away who do not have regular electricity to keep your medications working, do the medications work? So by moving into a DCB strategy, we eliminate the issue of stent thrombosis because there is no stent. So by developing techniques and using DCB strategy, we are approaching actually going back to the future, because for most people, they don't want to put metal in their coronary arteries. I think for most of us, we'd rather not to have any prosthesis. In the worst place you can be, proximal LAD, left main stem. If it's stent thrombosis, mortality is very high. So this is our study. We've compared 2 different DCB systems at our center, one with the Sequent Please and the other the Impact Falcon from the Medtronic company. And we compared this with de novo lesions with the DCB with DES in our center. And you can see for most of the patients, about 50% of them on DCB with chronic stable angina. DES a lot less, because we much prefer using a DES in an ACS setting to eliminate the risk of having prolonged balloon ischemic time. The lesion characteristics essentially are as follows. Most of the patients had a lesion length of about 20 millimeters. We use a DCB slightly longer at 2 millimeters overhang on both sides. A DCB diameter of about 2.5 to 3 millimeters. The outcomes when we compared both these drug-eluting balloon platforms, both of them paclitaxel, were actually similar. And actually, the only major difference is the excipient. And there are many other DCBs now in the market where we can start to explore and use this strategy for the management of our patients, particularly from the rural areas. So in conclusion from our study is that paclitaxel DCB seemed to be very feasible using the right technique with the right lesion preparation, right clinical setting, and advantages over conventional DES, PCI strategy. So without a stent, there is no stent thrombosis. But not all DCBs are the same, even among those in the paclitaxel family. So it's important to recognize the tools, the techniques, and measure the outcomes to validate how you're doing your PCI. So there are many, many common DCBs now. Of course, the most common ones are right at the top in many of our clinical settings. But I understand in America, they're just the agent coming on board. and parts of the world, other types of DCB. However, in China, we have many companies with drug-eluting balloons now, and actually very good to see the proliferation of this technology allied to the technique, so that you do not even eventually need a stent, a drug-eluting stent. So in Malaysia, in the last 10 years in our registry, we have more patients, more DCB. DCB is in the blue, and the DCB also in the yellow. You can see the numbers on the trending going up. And the DES doing PCI is actually dropping from 70 to down in the 60% mark in the country perspective. So this was where our journey started. This was our boss in 2010 presenting at a Euro PCR. Our first study, in-house investigator-initiated study using a combination using the CD34 platform as well as a drug-eluting balloon. At that time, it was very unusual to do PCI with a DCB in de novo lesions, bearing in mind most of them were the DCB have indication for in-stent restenosis or diffuse lesions. So we presented this, and actually very proud to also present this about in 2009 in the Great Wall meeting here in Beijing many years ago. So as you can see, a decade onwards, most of the Asia-Pacific consensus for DCB, half the authors are actually from Malaysia, just to vindicate our work in this area. And the technique for doing a DCB is clear. I mean, more on the right-hand side for de novo lesions, optimal balloon angioplasty. We start using a non-compliant scoring balloon, then high pressure, getting a good result after balloon inflation with a TIMI-3 flow and a FFR more than 0.75. And this was the case, and a DCB strategy is feasible. If not, if there's severe dissection, a drop in TIMI flow, and then a DES PCI strategy will be performed. The advantage for using antiplatelets post-PCI DCB is a short DAPT duration, 1 month for elective cases in high bleed risk patients, and 6 months for elective for chronic stable angina, especially if we're doing multi-vessel PCI. This is the second report published this year, again for DCB intervention for coronary artery disease, and this you can see in JAC Asia. And again, most of this from Malaysia, but the pioneering work also with Professor Shin from Korea, and Professor He as a first author. So DCB-based intervention for coronary artery disease, now very much recognized as a strategy, more localized and more popular, gaining popularity here in this region. And the basic idea is, after you prepare the lesion preparation, we have now more tools, doing a balloon, rotablation, atherectomy, more importantly, some lithotripsy. If you have acceptable results on the left with non-flow limiting dissection, residual stenosis of less than 30%, or FFR of 0.75, DCB strategy at 60-second inflation duration would present a very good option. On the right-hand side, if you have flow-limiting dissection, residual stenosis of more than 30%, or an FFR of less than 0.75, then you approach a DES or a vascular scaffold. As you know, there are many vascular scaffolds now made available after the issue of the absorb. You have now the FreeSolve NeoVas and the FreeSolve, and many of these other BVS now perhaps presenting you a PCI option without metal in your coronary artery. So this treatment strategy are now recognized in this paper in bifurcations. Sorry, I have to speed up because of time constraint. In the AMI situation, of course, you have to be careful, particularly the thrombus burden. If you have intravascular imaging advantages and whether you need to do thromboaspiration or not. Also, DCB in CTO, again, bear in mind to have optimal lesion preparation. And finally, in 2020, this is the International DCB Consensus Group, and you can see from this, they also focus very much on lesion preparation. So going back and remember how to do balloon angioplasty, of which many of my younger colleagues have forgotten because they're so used to doing direct stenting with a DES. So by doing careful balloon dilatation, preparing the result properly, you may well get away by having a DCB. By getting away with DCB is something misnomer, because it eventually would be the first option, either with a BRS, resorbable scaffold, or something that will prevent the acute occlusion of the acute recoil. So for this, I think it will be the standard of care going forward. And again, for our APSC, perhaps the better strategy for our population. So data-driven research, and I'm very happy to look at the pharmacoinvasive data from Indonesia because, as an archipelago, these are the challenges that we face. Developing new techniques and different clinical scenarios, having these peer-reviewed publications, which again is a hallmark of what the HS and a Great Wall presented in the opening ceremony, having ongoing national and regional registries, and finally, the pragmatic points, the operator and the patients. Despite the data, if you need to go on the angioplasty table, you have to go to the cath lab and yourself needing PCI, I'm sure you don't want to have it done at 2 a.m. You probably want to be the second case of the day when the team is warmed up. So this is our national meeting next year, our cardiology meeting in May. So I welcome all of you to Kuala Lumpur. The Twin Towers is the landmark place, and we hope to have all of you visit us for our meeting then. Thank you very much.